Hello, my name is Teresa Brannon. I am the Manager for Training and Technical Assistance at the National Center for Health and the Aging. I want to thank you all for attending today's webinar, Viral Hepatitis and Providing Care for Seniors. We are honored to have as presenters Ms. Corinna Dan and Dr. Bryce Smith. In summary, the webinar, Corinna Dan will briefly describe hepatitis epidemiology, Viral Hepatitis Action Plan and Call to Action. Ms. Dan will also focus on HBV testing recommendations for seniors, for example, cancer dialysis patients, HBV vaccination recommendations for diabetics, and CME resources and existing fact sheets, posters, resources, and Dr. Bryce will discuss CDC, HCV testing recommendations, and birth cohorts. Ms. Dan is with the Office of HIV, AIDS, and Infectious Disease Policy, OHA-IDP, at the U.S. Department of Health and Human Services as the Viral Hepatitis Policy Advisor working to implement the National Viral Hepatitis Action Plan and support coordination of viral hepatitis activities across federal agencies and the community. Prior to joining the OHA-IDP, Corinna served as Hepatitis B Policy Fellow at the Association of Asian Pacific Community Health Organizations, APCHO. In this role, Corinna worked with community health leaders and policymakers to promote improved prevention, diagnosis, treatment, and care of viral hepatitis in Asian American communities across the United States. Before joining APCHO, Corinna held positions in the Hepatitis Foundation International as a Chief Operating Officer and the Chicago Department of Public Health Hepatitis C Virus Program Coordinator. Corinna received a Bachelor of Arts degree in Asian Studies from Connecticut College, a Bachelor of Science in Nursing from Rush University in Chicago, and a Master's in Public Health from the University of Illinois at Chicago. Dr. Bryce D. Smith is a lead health scientist at the Centers for Disease Control and Prevention in the Division of Viral Hepatitis and currently serves as a lead for the Prevention Research and Evaluation Team. Dr. Smith has been in the division for 4 years, and his research has concentrated on hepatitis C prevention issues, including screening interventions and policy, economic analysis, rapid testing, primary and secondary prevention with persons who inject drugs, and health services research. Dr. Smith recently led laboratory and field evaluations of HCV rapid point of care tests and is first author on the recommendations for the identification chronic hepatitis C infections among persons born during 1945 to 1965. Prior to working in hepatitis, he worked in the Division of HIV AIDS Prevention at CDC. I now would like to present Ms. Corinna Dan.
Great. Thank you so much, Tricia. And thank you, North American Management, for inviting myself and Dr. Bryce Smith to discuss viral hepatitis as it applies to serving seniors. And one other piece of experience I'd like to let folks know about is that my dream job out of nursing school was to go work at Erie Family Health Center, which is a community health center in Chicago. So I have that experience too. So we really focused this webinar today on recommendations around viral hepatitis for serving seniors. So as you mentioned, we'll do just a brief overview of epidemiology, the action plan, and then those specific recommendations that we felt were really important for healthcare providers that serve primarily seniors. And then there are some fantastic new resources that I'm excited to share with folks for moving beyond sort of the elementary information that I'm going to present today to give a little more training for providers on the ground. So overall, most people don't recognize how many new cases of hepatitis B and C there are in the United States. It's estimated by the CDC that there are about 35,000 new cases of Hep B in the U.S. every year. This is a significant decrease since 1991 when the safe and effective vaccine became available. We estimate now that there are upwards of 1.4 million people people chronically infected with hepatitis B in the U.S., and we do still have some perinatal transmission of hepatitis B, with about 3,000 people every year in the United States estimated to be dying from their Hep B infection. However, the death sort of documentation of death due to hepatitis B is fairly poor, so it's likely that the death is somewhat of an underestimation. Hepatitis C virus, about 17,000 new cases were estimated by CDC in 2010, with about 3.2 million people chronically infected in the U.S., and Bryce will go over this in more detail, but 15,000 people estimated to have died of hepatitis C infection in 2010. So in response to those huge numbers, the U.S. Department of Health and Human Services put together a viral hepatitis action plan, which was released in 2011. And just prior to the action plan, there was an Institute of Medicine report released in January of 2010, which also highlighted and sort of, I think, started to mobilize HHS to really look at how we should be addressing viral hepatitis in the U.S. So there are 6 sections in the action plan that you can see here, and one of the most important and the one that we've spent the most time on thus far over the past 2.5 years is really educating providers and communities to reduce the health disparities. And so I'm really excited today to be talking to folks on the provider side who can help get patients into care and provide people with the care they need once they're diagnosed. So that action plan proposes that we need to increase the proportion of people who are aware of their hepatitis B infection, because when the plan was put out, it was estimated that only 33% of people with chronic Hep B infection were actually aware of their infection. The second goal is to increase the proportion of people who are aware of their Hep C infection. And so again, the role of testing is critical in increasing the proportion of people who are aware of their chronic hepatitis infections. And then we also want certainly to reduce the number of new hepatitis B infections and eliminate mother-to-child hepatitis B transmission. Now, we hope to be able to achieve these goals by 2020, and that is contingent on mobilizing resources and folks to really implement the goals of the action plan. So in our office, you mentioned the Office of HIV/AIDS and Infectious Disease Policy. We have a cross-governmental, cross-departmental implementation group. We've got buy-in from all of the agencies within HHS and some of the offices as well, like Office of Minority Health and Office of Women's Health, but also the Department of Veterans Affairs, Department of Justice, Bureau of Prisons, and our newest member is the Department of Housing and Urban Development. So we really are trying to identify ways that we can in the environment today with the economy not being as strong as it has been in past, and with the Affordable Care Act being implemented, looking for how we can move forward with the goals of getting more people tested and into care for their chronic hepatitis. And you can learn a little more about what HHS has done, what all of the partners that are implementing the action plan have done at on our website at aids.gov with the implementation progress report, which there's a link there at the bottom of the page. So the IOM report, going back to 2010, really found that insufficient provider knowledge was leading to some of those missed opportunities. And I'd like to just point out that those are still opportunities, real opportunities for providers to educate patients about hepatitis B and C, help prevent new infections, and also to identify patients and test them for hepatitis B and C. So straight out of the IOM report, we are implementing the recommendations that pretty highly regarded group brought up. And I think now Dr. Bryce Smith is going to talk about the very exciting new hepatitis C recommendations. And I know there's a slide transition here.
Well, good afternoon, everyone. Excuse me. I'm going to get my slides set up there. I think everybody should be able to see that now. Excellent. And I also want to say thanks for having me on the call today. I've had the opportunity to talk with a number of different groups, and I find that it's always very helpful for me to get the perspective of different providers or advocacy groups. I've talked with folks in labs, and all sorts of different people, and it's always really informative for me to get different perspectives. And so, as Corinna said, I'm going to be talking about our recent recommendations to identify chronic hepatitis C infection among persons born from 1945 through 1965. Corinna's given some background there, so I'm not going to belabor that too much, but talk about what our current recommendations are, what some of the limitations of those are, and then give you a sense of our consideration to do a very different strategy, a prevalence-based HCV testing strategy. Tell you a little bit about the methodology we used for our evidence review, talk about the recommendations, and tell you what we've been able to do so far in terms of implementation. And as Corinna said, if you kind of go all the way to the end of this slide, I'm having a hard time seeing that. Let me make that go away. Oh, never mind. And so, if you go all the way out to 2008 on this slide, that's where you start to see that number of 17,000 new cases a year that Corinna mentioned. But you can see the incredibly high levels of incidence or acquisition of HCV infection throughout the 1980s. That was really about 250,000 persons per year over the 1980s, really just tremendously high. And that was for a number of different reasons, one of which, probably the primary reason, is that prior to 1992, we did not have a sensitive assay to be able to find, detect HCV in blood, particularly in the blood supply. And so we saw a lot of nosocomial infections, infections that occurred just when folks were giving blood, or particularly like when they were receiving blood prior to 1992, or receiving an organ or some sort of transplant. That's really probably one of the biggest ways that folks acquired the disease during that time. We also saw a lot of new infections among persons who inject drugs during that time. That declined significantly as we moved into the 90s, which really had more to do with really the pool or the entire population of persons who inject. And unfortunately, the prevalence among that group is as low as 30% and as high as 70, 80, 90%, really depending on how long someone's been injecting. But as you can see, incidence has really declined significantly. And the consequence of that, interestingly, is that while we don't necessarily see a whole lot, relatively I should say, a whole lot of new cases, we have this very large age wave, if you will, of HCV infection among persons who acquired HCV either in the 1970s or 1980s. And so, in terms of chronic HCV, we estimate between 2.7 and 3.9 million persons in the U.S. are infected. We know that HCV is the leading cause of liver transplants as well as cancer. And unfortunately, it's still the fastest rising cause of cancer-related death in the U.S. We put out a very interesting article recently that found that HCV-related deaths had doubled from 1999 to 2007, increasing to over 15,000 a year. Early data that we've looked at for 2008 shows that at about 16,000. We have, in some of our modeling, we've looked at what that death rate would continue to be in the absence of any intervention, and so no testing and no treatment. And that would increase all the way up into the 2030s, where it would be over 35,000 persons dying a year. It's really, the numbers just get staggering. One thing I find that's usually really helpful is I think people tend to be a little more familiar with HIV, and so trying to get, understand HCV in that context I think is helpful. In the U.S., we know that about 1.2 million people are living with HIV or AIDS, but we also see there that about 3.2 million persons are living with HCV. The Venn diagram, I think, helps to really highlight the fact that about 25% of the persons who are living with HIV also have HCV. We know that the leading cause of death among persons right now with HIV is liver disease, and HCV really is the primary contributor to that in the U.S. This is a nice table that highlights that those rates of mortality that I mentioned earlier. In the green line, you see hepatitis B runs along the bottom. There's really not been a lot of change in terms of mortality for hepatitis B. The red line is for HIV, and we've really seen some very significant improvements in reduction of mortality, which has a great deal to do with improved medications and more people getting on medication so that we now see death rates moving much lower. Unfortunately, the yellow line is for hepatitis C, and that's where we really see quite a marked increase. And unfortunately, as I mentioned earlier, we're expecting that to increase even further. So we'd really like to learn from some of the successes that HIV has had and be able to implement that for HCV. We also did another study looking at, in 2007, more than 70% of all registered deaths among persons who were HCV infected were aged 45 through 64 years old, which will kind of lead into my discussion of the birth cohort in a minute. For those of you all who are familiar with HCV therapy, apologies, I'll cover this quickly, I promise. But there are a number of new therapies for HCV infection. The goal of therapy for HCV is clearance of the virus. This is known as a sustained virologic response, which one can determine through serology at either 12 or 24 weeks after completion of treatment. While HCV therapy is effective, it still has a pretty significant risk for serious adverse events. The risk is probably higher than 5 to 10%. That's really more about discontinuation related to those adverse events. There are a number of new medications out. These are called direct-acting antivirals, which are different from interferon, which has been the standard of care for about a decade, a little more. And so what we see is these new direct-acting antivirals are not just supporting the immune system, but actually taking on the virus itself. So we've seen increases in effectiveness from 40% to over 75%, and it's also really been able to shorten the length of treatment. There are a number of drugs, more than 20 at this point, that are in phase 2 or 3 trials. Many of these have over 90% effectiveness, and these are all direct-acting antivirals as well. They have improved safety and tolerability profiles. There are 2 that just went to the FDA in the last month, and it's really, this is an area that is just exploding. It's kind of like HIV was in the mid to late 90s when all of a sudden there were new medications on the market everywhere, things coming out every single year, and we'll see cocktails and some of those things coming together. The ultimate goal, and my colleagues who are hepatologists really let me know that, the ultimate goal, and they think this will happen probably certainly within the next 2 or 3 years, is that we could get down to a single oral pill that would also be a short treatment, like 12, 24 weeks max, that would have high levels of effectiveness as well as really low levels of, improved safety and tolerability profiles. So these are our recommendations from 1998, and I think it's important to really acknowledge that the new birth cohort recommendations supplement these. They do not supplant them. So certainly any patient that were to come into your office, if they presented with a past or present injection drug use, of course you would go ahead and test them. Our recommendation is not to skip that. It's to include that. Any signs of liver disease, as I mentioned, if you'd received blood or organs prior to 92 or blood products made prior to 1987. If someone's ever been on chronic hemodialysis, because certainly dialysis clinics, unfortunately, there's an awful lot of blood around. And HCV is a highly infectious virus that can live for days, even just on a countertop, even after it's been washed with bleach. HCV is a tough one. And then also infants who were born to HCV-infected mothers, and then those persons with HIV infection. So there are significant limitations, though, to these risk and medical indication-based testing recommendations. There are a lot of barriers, not the least of which is physician knowledge and experience. A lot of docs are unfamiliar with what sorts of serologies they should order, even when they get those results back, not really clear how they would interpret them or what their next steps would be. And there's also certainly the issue of patient willingness to disclose, long past risk behaviors, concerns of stigma. If someone injected 1 or 2 times, say in the early 70s, well, they don't really want it, at this point, given their age and their, their more senior status, they don't want to admit that to their primary care doc. And I can guarantee you their doc isn't going to ask that question either. So when we look at liver function tests, and those are really, we hear from a lot of primary care docs and family care docs that you should really just focus on liver function tests, because that gives us a good idea of what's happening in terms of inflammation in the liver. But the problem is we know that it misses more than 50% of chronic cases. And of those persons who have persistently normal liver enzymes, we know that 20 to 30% of them are going to go on to develop serious liver disease. And this is a very big concern. We're talking about missing an awful lot of people. We've also done, if I could just briefly say that we've done another analysis looking at 4 large primary care sites, and of all persons who had an elevated ALT, which is about 10% of over 200,000 patients over a 5-year period, of that 10%, less than a quarter of them who did have this elevated ALT were actually screened for HCV. So that's clearly not a very effective method either. At this point in the U.S., we estimate that anywhere from 45% to 85% of infected persons are unidentified. I'll tell you, this range drives me a little crazy, but the reality is that we have large studies on both sides of this range. We've got a 5-site natural history study where that 45–50% came from, and it just concluded an analysis of that the 4 primary care sites, folks who are already sensitized to HCV, and we estimate using a very rigorous imputation methodology that about 81% of those persons who are infected are currently unidentified. So given the serious limitations of these new, of the old risk and medical indication-based strategies, we decided to take a look at doing a prevalence-based strategy. We focused first on the 1945 to 1965 birth cohort because they'd been identified in previous CDC analyses where we did estimates looking at the NHANES data of HCV infection in the U.S. We know the persons in this birth cohort are 5 times more likely to have HCV than other adults, so those aged 20 to 70 but who were not born in those birth years. And the anti-HCV prevalence in the birth cohort is 3.25, meaning that 1 out of every 33 persons who were born in this birth cohort have been infected with HCV, and then 75% of them will go on to develop chronic infection. Of all the HCV chronic infections in the U.S., 76.5% of them are in this birth cohort. And when we look specifically at this group, we find that 68% of infected persons in the cohort have medical insurance, and they have some really significant modifiable disease cofactors. As you can see there, and this is looking at self-report data when it comes to alcoholic drinks per day, 58% of infected persons in the birth cohort reported that they consume more than 2 alcoholic drinks per day. That is an awful lot of drinking for persons who already have a serious liver disease. And being able to reduce that would be quite significant. So we looked at the evidence using a particular methodology, which is called the GRADE framework. At this point, this methodology has been adopted by over 60 organizations worldwide, WHO, ACIP, Cochrane Collaborative. And what it does is it's really kind of a 2-stage thing. It assesses the quality of the evidence for critical patient-important outcomes, and it determines the strength of the recommendations. I'm working with a colleague right now, and we are helping WHO go through this process of using these, using the GRADE methodology, and we'll be out there at the end of June to help them start to finalize their HCV screening, testing, and treatment recommendations. So we did a stage review when we first selected our target birth cohort, and then we, our second piece was evaluating the benefits of harms of testing this population. So I want to go over briefly just the top-line findings of these. Related to harms, the effect of protease inhibitors, these are the direct-acting antivirals, on serious adverse events increased. It went above what we saw with interferon and ribavirin alone. It increased by about 33%. We got a lot of feedback working with our external working group that we needed to consider insurability, HCV transmission, false positives, false negatives, all as potential harms. But as I'm certain you're not surprised, there's really no data out there related to that, even if we look at the birth cohort or even when we expand it to all adults. And so now I'd like to talk a little bit about what the benefits are. And so when we look at these new direct-acting antivirals and we look on the association of these with a sustained viral response, we found that persons who are on these medications are 50% more likely to achieve an SVR. And that's critically important, as you see, because SVR is also associated with liver cancer. So those persons who achieve a treatment-related SVR, those persons are more likely to have a reduced risk of liver cancer of 75%. Well, this is really tremendous. And that was a systematic review looking at over 32 different articles, and it found the same thing for a stage of liver disease, too. There's also an excellent paper out by Lisa Backus and her colleagues at the VA that were able to associate SVR and all-cause mortality that found that those persons who had a treatment-related SVR that was associated with a reduced risk of all-cause mortality of 50%. And that's really that is the thing that you're going for when it comes to being able to make a recommendation like this. And given the high levels of alcohol use, we also looked for clinician-directed, any sort of evidence related to clinician-directed interventions. And there are a number of them out there. There's an excellent meta-analysis that finds a decline of alcohol use of over 38% for over a year of follow-up when provided a clinician-directed intervention. Now, this wasn't specifically for HCV-infected populations, but there's not really any reason for us to think that that will be different. This is a picture of our MMWR recommendations that came out last August. We're quite thrilled to have those out. I certainly am. And the recommendations themselves, any adult born during 1945 through 65 should receive one-time testing for HCV, and you do not need to do prior ascertainment of HCV risk factors. That's a really big piece. If someone comes in and they're born in 1950, you don't need to ask them if they ever injected drugs, which is a question nobody really wants to ask their patients. So this helps us to kind of get around some of the limitations from those risk-based strategies. Also, we looked at those persons with identified HCV infection should receive a brief alcohol screening and intervention as appropriate, and this should be followed by referral to appropriate care and treatment for HCV infection. And that's something that is very often missing in the types of recommendations that come out of CDC and other places, and we really wanted to focus on that and make sure that that was a significant part of our recommendation. So folks will ask me, well, what is this really going to matter? How is this really going to help? And so we conducted an analysis, a modeling analysis, where we looked at the health and cost impact of what it would look like if we tested all these persons within the cohort and then provided them with the newer medication, the PEG interferon ribavirin, plus one of the direct-acting antivirals. Well, first off, just doing the birth cohort testing itself, we would identify over 800,000 new cases that wouldn't be identified using current risk-based strategies. And that is hugely significant. And as you read down, you can see the number of different morbidity and mortality that can be averted. And in particular, I'd like to draw your eyes to the deaths from hepatitis C averted would be just over 120,000. And now as these medications improve, I think we can expect to see that number increase. And that's something we're really excited about. This also presumes a relatively low level of treatment access, being able to actually go into treatment and complete it. And if we're able to increase that, that's something that I think could be really tremendous. This is a very effective intervention at a cost per quality, a societal cost per quality of just over $35,000 per quality adjusted life year gained. And to put that in a little bit of context, if we compare that with other routine preventive services here in the U.S., this is really in line with all of these very routine services, generally to be considered cost-effective in the U.S., it has your intervention has to be $50,000 per QALY or less. And so you can see that these are all standard colorectal screening for persons age 50 or higher, hypertension, age 30 or higher, HBV testing, colorectal screening, even breast cancer screening. And so, you know, this particular intervention falls really right in the middle of all of these routine preventive services. So it really makes sense, even from a cost perspective, for us to move forward with that. I'm just going to cover implementation really briefly. I'm just going to talk just a little bit here about launching our No More Hepatitis campaign for public and providers. As you can see, there are a number of other things that we're doing. I'm not going to talk a lot about that today. I want to focus on some things that you might have seen and some ways that we're trying to reach the community. We've got a campaign called the No More Hepatitis campaign. It's a multimedia campaign that we started in 2011 at the very first World Hepatitis Day that we were able to announce at the White House. The first campaign wave, which is still undergoing, is really working to build general awareness. We started this in May of last year, which is Hepatitis Awareness Month. We also had our first Hepatitis Testing Day last year, May 19th, and as you can imagine, we're gearing up for that right now. We've also already started phase 2, providing more provider communication for the new testing recommendations, and we've also been developing a number of education materials for that as well. And phase 3, which will begin shortly, is really around consumer communication for new testing recommendations for persons in the birth cohort. Hopefully you've been able to see one of these dioramas. We have these in various airports all over the U.S. We've been incredibly fortunate that they have been, all the space we've used has all been donated, and at this point we really have over like $4 million worth of resources that we've received in gifts to be able to put these up. We have these, we have several of them, and some are more specifically focused on the birth cohort itself. They're in D.C., Atlanta, we have some in Salt Lake City, Las Vegas, so they're really kind of popping up all over the country, and I'm always really thrilled to see this out there. This is looking at National Hepatitis Testing Day. We tried to coordinate a lot of local activities here on our national map so that when persons are looking to find hepatitis testing events, they can go onto this site and be able to find, well, what's the nearest testing location to them that they might be able to go receive testing. I'd mentioned that we're working to train providers in this implementation. We're targeting providers. We've talked a lot with primary care organizations, clinical specialists, and public health funded programs. And we've conducted a lot of different things like distance learning, presentations, and we've developed model curricula as well. So thank you very much.
Great. Thank you so much, Bryce. This is, I really appreciate your time this afternoon, and also presenting that science is so critical. In addition to the fantastic new hepatitis C testing recommendations that Bryce is the lead for, there are other hepatitis services that providers should consider for seniors, especially as they're caring for them. And right now, I'd like to talk for a couple minutes about hepatitis B testing. It's a fairly long, involved list of folks who are recommended for hepatitis B testing according to the CDC. But in particular for patients who were born in Asia and Africa and other regions with moderate or high rates of hepatitis B, and I've got a map on the next page, those folks should be tested for hepatitis B. Additionally, as I think Bryce, maybe Tricia mentioned earlier, people who have been on hemodialysis or are on long-term hemodialysis, or people who receive chemotherapy or other types of immunosuppressive therapy, these two at the bottom of the list, should definitely be tested for hepatitis B prior to starting chemotherapy. or other types of immunosuppressive therapy, or again, if they're on hemodialysis. Certainly the other recommendations for hepatitis B testing may apply to some of the patients who are seniors, but I did want to try to focus this talk on services for seniors. The fact is that both hepatitis B and C testing are important, but people with chronic hepatitis really often don't know they're infected since they don't look or feel sick, and that makes the actual blood test itself more important for providers to recommend and then to get patients into care. Over time, approximately 15 to 25% of people with chronic hepatitis B will develop serious liver problems, and folks are dying. So this map shows in the darker green the highest prevalence of hepatitis B globally, also shows the intermediate, and the CDC recommendations are that anybody who comes from an area of intermediate or greater than 2% or greater prevalence for hepatitis B should be tested at least once for their hepatitis B infection. The American Association for the Study of Liver Disease has recently been trying to elevate the issue of hepatitis B testing prior to immunosuppressive therapy. That can include chemotherapy for cancer, immunosuppression related to organ transplantation, but also things we don't think about quite as often, rheumatologic disorders, gastroenterologic disorders, and dermatologic disorders for which immunosuppressive therapy is recommended. So the recommended tests include hepatitis B surface antigen, or HBsAg, the anti-HBC, which is the core antibody, and the surface antibody for hepatitis B. Unfortunately for providers, often different labs will have different sort of shorthand or abbreviations for these markers of Hep B infection. So it may be best to check with your lab. CDC.gov/hepatitis also does have resources such as serology charts that you can refer to because the hepatitis B, especially the hepatitis B serology, can be fairly complex. Prophylactic antiviral therapy for people who have hepatitis B in advance of the immunosuppressive therapy is recommended, and once a provider identifies a patient who has hepatitis B, it's probably a good idea to consult with a specialist prior to initiating that new immunosuppressive therapy. Seniors also are recommended in some cases to get the hepatitis B vaccination. Overall, in the United States, we've had a very successful strategy to eliminate transmission of hepatitis B virus using the safe and effective vaccine that's been available since the 1980s. Universal infant vaccination is most of the reason that we have reduced the number of new cases of hepatitis B on that first slide I showed by about 82%. But vaccination of previously unvaccinated adults who are at risk for hepatitis B infection is another component of really eliminating transmission of hepatitis B in the United States. I didn't want to downplay the long list of recommendations for adults who should be recommended for hepatitis B. So I included here certainly people who are at risk for infection because of sexual exposure, due to infection exposure to blood, and then others. So I included the entire list. But I wanted to focus specifically on the most recent hepatitis B vaccination recommendations for diabetics, which only was released in 2011, that hepatitis B vaccination should be administered to unvaccinated adults with diabetes aged 19 to 59. That is given an A recommendation, but also that hepatitis B vaccination should be administered to those over 60 at the discretion of the treating clinician. The rationale behind this is that 29 outbreaks reported to CDC that occurred in long-term care facilities. Of those 29, 25 of them involved adults who were receiving assistance with blood glucose monitoring. So when CDC went in to determine the cause, those outbreaks were caused because of blood glucose monitoring of diabetics. With hepatitis B, as Bryce mentioned earlier, Hep C is a very hardy virus. Hepatitis B is actually even more hardy and can live outside the body for up to 7 days, even in dried blood, including on surfaces, and certainly in the context of blood glucose monitoring can be very easily transmitted. So we have a number of challenges, not the least of which is that awareness has, historically been very low about viral hepatitis. So we want to certainly raise awareness, and Bryce mentioned the public awareness campaigns, the provider campaigns, and the resources that I will show in just a couple minutes. We've got some really exciting new hepatitis C therapies coming down the pike, which makes it even more important to identify patients who are chronically infected with hepatitis C, because we can really prevent death due to hepatitis C if we can identify them early and get them into care. We want to improve the data. Bryce gave us a range of data for some of the stats that he shared, and part of the reason that we have these ranges is because the data just hasn't been as available as we'd like for it to be. And certainly taking advantage of the Affordable Care Act and the expansion of healthcare access to get folks into care and get them the quality of care around not just viral hepatitis, but certainly holistic patient care is the goal. But in terms of viral hepatitis, we'd love to continue to push the boundaries of leveraging resources and raising awareness to get folks into care and to really see those rates of death due to chronic hepatitis B and C getting lower instead of higher, and really turn the tide on hepatitis B and C in the United States. So just in the last couple of minutes here, I'd like to go through some resources. CDC developed a fantastic hepatitis risk assessment, which can be done by an individual or an individual with assistance online. It takes about 5 minutes, and what the person who does the risk assessment will end up with in the end is a list of recommendations based on the CDC, all of the CDC documentation for hepatitis B and C, for testing and for vaccination. So it's a very cool tool, one that you may be able to ask patients to do in advance of an appointment or an exam, or even work into some part of your clinic flow. Another great resource that some of Bryce's colleagues at CDC have funded is Hep Web Study, which has free continuing medical education credits online. It's a beautifully done, self-paced learning site with modules for hepatitis B, hepatitis C. There are also modules for hepatitis A, and really giving providers all of that background information that they can use to better understand disease progression, some of the more the details of hepatitis B and C infection and the virus. And coming soon, this website will also have more information about those emerging therapies as well, although I don't think they're quite up yet. There are some, there already are modules on the dual therapy with pegylated interferon and ribavirin, but the new therapies will be online at this site soon. NoHepatitis.org is the other training website that CDC has developed. in collaboration with the University of Alabama at Birmingham. Some great materials here, more targeted to specific populations as well as specific venues such as substance abuse treatment and outreach. I also wanted to share the VA site because the VA recognized about almost 15 years ago that they had a major problem among veterans with chronic hepatitis C and have really a very advanced program. And so they have a lot of provider tools, some real great clinical tools like checklists and flow sheets to really help providers who are short on time and need those kinds of tools to really effectively care for patients in a clinical setting. Those are available currently on the VA website. Bryce mentioned the No More Hepatitis campaign, and I would encourage all of you to go check out the goodies that are there. There are some great online resources, including quizzes and buttons and badges that people can put on, or clinics or providers can put on their websites that lead directly to the risk assessment or other resources online. And May is Hepatitis Awareness Month, so this webinar is very timely. May 19th is National Hepatitis Testing Day, and so there are free resources also available for order as well as for download on the CDC website here. Thank you all so much. Really appreciate the opportunity to share this information and would love to entertain any questions at this time.
Thank you, Corinna, and thank you, Bryce, for your time and your expertise on this important topic. It was a really great presentation. Let's see, I have a question. If you had stated something about, and I think this might be more for Bryce, stated about trying to prevent hepatitis C crossing over to infants during pregnancy. When you're treating a woman that's pregnant and she gets that treatment, what's the likelihood of her getting the hepatitis C again if she doesn't, if after treatment? What's the likelihood of her getting hepatitis C again?
So I want to make sure I understand. So first off, it's contraindicated for a woman who's pregnant to receive therapy. And
okay.
So that's the first piece. And does that answer the whole question or no?
Yes, that answers the whole question. Okay.
Well, the other piece about reinfection, though, I think may be an important one, that hepatitis C, if it's treated and the patient gets a sustained viral response and does not have any virus, circulating, they can be reinfected if they're exposed to hepatitis C again in the future. So the treatment, gets rid of the virus, but it's not protected. The patients aren't then protected. So unlike chickenpox, people can get hepatitis C again, even if they're treated successfully.
Okay. Great. That answers the question. Thank you. Both questions. Let's see if there are any other questions. I don't have any other questions at this time. If there's anything that you or Dr. Bryce would like to speak about and more about hepatitis C and the program at CDC, we have about 10 more minutes.
Is there anything you'd like to add, Corinna?
I think I covered everything that I had in mind to cover. I hope that folks will, take advantage of the online resources and consider, testing more patients for hepatitis C, testing the appropriate patients for hepatitis B, and I really appreciate all of those folks who took the time today to log on and listen to the webinar.
Well, I would like, oh, sorry.
Oh, no, go ahead.
No, go ahead, Bryce. Sorry about that.
I was just going to say that I know oftentimes clinicians and providers have concerns around implementation. How will implementation of the first cohort strategy really work? And I just wanted to let folks know that we're currently, we've funded, I think, about 10 different sites under a programmatic cooperative agreement to implement that strategy, and we're talking with them now about the implementation that they're using to do for that. We also have a couple of more, let's say, kind of a more rigorous studies where we are specifically evaluating the implementation of first cohort strategies in primary care settings, and we're looking at a number of different ways to do that. People tend to think that, oh gosh, we can just do it right in our EMR, we'll add a best practice alert so it will pop up. And while that sounds really simple, it ends up frequently being harder than we might expect. And so we're trying to look at a number of different implementation strategies, and as soon as we have that information, we're going to be sharing it, because I think sometimes it can be a little daunting thinking, gosh, how in the world will we be able to do something like this? So we're trying to provide support, different strategies for ways to implement what was really a pretty significant screening policy.
Great. That was great. We don't have any more questions, so I just would like to say to all the attendees, thank you for attending this webinar. And if you need any training or technical assistance, please contact one of our talented staff members for any assistance. And once again, Corinna and Bryce, thank you very, very much for your expertise on this important topic. And we hope to have you back once next year to talk about any changes and updates.
Super.
Thank you.
Great. Thank you.